The last speaker of this session is Professor Massimo Fresta. Professor Fresta is a full professor at the Faculty of Pharmacy at the University of Catanzaro. His long academic career is difficult to summarize. I would like to remember the PhD concerning the technology of bioactive molecules. He was a visiting scientist and professor at the École Polytechnique in Zurich. The research of Professor Massimo Fresta is mainly focused on the development of innovative drug delivery system like liposome, niosome, nanoparticle, cyclodextrin, and microemulsion. And
because otherwise we are out of the time. I think it's enough. Thank you for the presentation, Roberta. Okay, thank you everybody. And my presentation deals with possible advantage of an in vivo model, and I would like just to convince you in some way, in some way, just the suitability of this model. As you can see, this presentation, this work comes from, actually it's not a collaboration, it's another part of the soul of my group, belonging to the CNR, belonging to ARPACAL, concerning the pharmacological point of view. Just concerning the central nervous system, unfortunately, the problem is that a lot of drugs, this is the reason why we are here, just to discuss on that. And the fact that a lot of drugs are not able just to trespass the blood-brain barrier, we have learned just concerning the presentation, before my presentation, that we have the possibility to have a selective passage. We have some kind of transporter. Also, the last question concerns some kind of transporter, like GLUT1 and GLUT2 transporter, and especially GLUT1 receptors. And also we have some evidence concerning the fact that lipophilic compounds can in some way diffuse. Of course, we have some kind of implication concerning the pharmacokinetic point of view and the binding with serum proteins. But what is really difficult is the fact that hydrophilic molecules, for sure, are really difficult to pass the blood-brain barrier. Unfortunately, concerning the pharmaceutical company, really a lot of drugs are not, suitable just to be used in the treatment, in clinical practice. And so it was estimated about, as you can see, the 98% of drug files just to be used in therapy. And a successful strategy that was proposed in last years concerned the use of nanoparticles. And there was just recently, we are here hosting in Modena, and Professor Vandelli group are carrying really an excellent work concerning this aspect for the active targeting of the blood-brain barrier. It was really a nice work. I think it was a lead work, let me say, in this field. It's just not a compliment, Mariangela is my real feeling. But another point, was born in recent past was the fact that the possibility that particles in some way coated with Win80 can pass the blood-brain barrier. And it was a really disputing point because the mechanism was not so clear. I just choose, and I would like just to draw your attention in these papers that was carried out by the group of Patrick Couvreur in Paris, and in which at the very end he claimed that, of course, the Win80 coating could be a strategy because of the presence of apolipoprotein A. And so this kind of pathway could be used just to target the blood-brain barrier. Just starting from this experience and just listening to the other part of my group working on pharmacology, we would like just to investigate a possible model, because a lot of models consider the anti-nociceptive effect of some kind of peptides, In this case, of course, we start just to prepare nanoparticles, PLA nanoparticles, coated with TUN80, and we loaded within these nanoparticles tacrine hydrochloride. I just stressed and marked in red because, this is the point of this presentation. Of course, we have carried out the physicochemical and technological characterization of our particles, a mean size of more or less of 200 nanometers and polydispersity index of 0.1. That means really an homogeneous size distribution. And amount of tacrine entrapped within PLA is more or less the 45% used just for the preparation of these particles. And we carried out also the release in the present serum of the tacrine, of the entrapped drug. And in this case, I'm forcing my identity as a technologist, and I would like just to be a little pharmacologist, let me say, because I would like just to draw your attention on this first part of the release. What I would like just to tell you that in the first part we have really a small release of that tacrine. Why I'm stressing this point? Because all the experiments that were carried out in this model were carried out just in 60 minutes. That means that what is really important just to distinguish the passage of a drug delivery system or the passage of the drug. If I have the leakage of the drug, generally I'm not able just to distinguish the passage of a simple drug or the drug-loaded carrier. In this case, the release, the leakage in the very beginning is really small. And so the in vivo model, I just stressed and marked in red tacrine. White tacrine is a cholinesterase inhibitor, and in the presence of lithium chloride, produce motor and electrocorticographic seizures and delay hippocampal damage. This kind of model is normally used in epilepsy because of the generation of this kind of seizures. And what is really important in this kind of model is very well defined in terms of time of onset of the spike of electroencephalographic seizures, and also in terms of behavioral and morphological changes occurring in the CNS. The effect of tacrine are directly related to its entrance in CNS. That means that we have not peripheral effect, and the effect follows a dose-dependent profile, and as I just told you, no peripheral action is concerned with tacrine. That means, just looking on this advantage of this model that is used just to study epilepsy, that we are dealing with a model that can allow us to have an evaluation not only in terms of qualitative effect, but also in terms of quantitative effect, and in the meantime also in terms of kinetic, because we can measure the onset of the effect. That means that we can measure the rate of the phenomenon of the effect. And so, I just told you, therefore, the presence of significant variation in neurological effect, onset of the electrocorticographic seizure, behavioral and morphological changes, eventually occur in animals treated with same dose of tacrine administered by different formulation, could be used as a parameter to evaluate the penetration rate of this drug in CNS. And so the aim was just to evaluate this possibility. And so start with the experimental model. I just told you we prepare nanoparticles containing tacrine. We use in this kind of experiment Wilster rats. 1 week before, electrodes were chronically implanted in the cortex. The treatment with lithium, we start after 1 week the treatment with the lithium chloride, and after 24 hours we start the treatment with the tacrine as a free drug, as a drug entrapped in nanoparticles. And we start the evaluation in terms of electroencephalographic variation, in terms of time of onset of the seizures, in terms of morphological change of the brain. Just to let you know what happens? Here we have the control group. I would like just to say, unfortunately, I don't report any data on that. We have no effect of the nanoparticles, of unloaded nanoparticles. We start the treatment with tacrine aqueous solution, free tacrine, and this is the results. I just told you, everything happens in 60 minutes. We start also the treatment with nanoparticles containing tacrine. In this case, we have the appearance of this kind of seizures just 10 minutes after the administration, the intravenous administration. Also, in terms of damage, we can recognize a difference because here we have the control, here we have the free tacrine, and also the damage caused by the tacrine-loaded PLA nanocapsules, in this case, is huge and is bigger than the free tacrine. I just promised that it's possible just to have, let me say, a kind of quantitation of the effect. It is a table that shows this point, in which we have the start time of the symptoms, and here we have the free tacrine. We have a start, that the start point is more or less 22 minutes, and 10 minutes in case of nanoparticles. In case of the presence, and so the morphological, the histological analysis, in this case we have the presence of damage in the CA1 hippocampal zone in 6 animals on 10, and all animals treated with nanoparticles present this kind of damage. And just looking at this result, we can conclude that the pathway concerning, the twin 80 and the presence and the possibility to have an absorption of the ApoE just on the surface on the nanoparticles could be, a pathway that can allow the nanoparticles just to cross the blood-brain barrier. At the very end, this, you are not able just to find this experiment in the abstract because it's really less data. Last week, we carried out this kind of experiment with this apparatus. It's an in vivo fluorescence microscopy. And this is, all the apparatus, the probes that are able just to recognize fluorescent probe. And we carried out this kind of experiment in which, with our stereotaxis apparatus, we inserted the probe, the optic fiber, just in the brain of rats, and we measured the appearance of fluorescence due to the fact that we have loaded fluorescein just within nanoparticles, just to have another in vivo evidence of the passage of the blood-brain barrier. Unfortunately, I would like to show you I don't want just to spend so much time, but just to let you know, if it's possible, what we are able to see. I don't know if it's possible to see. Maybe here, unfortunately, because of the light, it's not so easy to see, but okay, it's a question of fate, believe me. In this case, you are seeing, let me say, the liver, but also in case of brain, because here we have the movie of the brain. What is appearing? We have the fluorescence in the brain, and so nanoparticles and fluorescent-loaded nanoparticles and nanoparticles coated with twin 80 can reach the brain. So, just the conclusion of this presentation. I carried out almost a mistake. In any case, I would like to convince. I will try to convince that this model, could be a suitable tool to investigate the passage of, in this case, of nanoparticles, but in general, of a carrier through the blood-brain barrier. And concerning the fact that, as just like my colleague before me, Professor Smith, the very end of this presentation concerning the stimulation of the discussion that Paolo pushed everybody is just to put, normally you put question, I would like just to put you a question. Is it enough as an evidence just of a BB passage, the evaluation of the CNS effect of a drug that exerts non-peripheral effect, or we absolutely need the evidence of the presence at the level of the CNS? This is the question. Why? Because I work with a lot of time concerning the blood-brain barrier, let me say the brain delivery, and sometimes happens when you try to publish a paper on that reviewers have different position, and in some cases ask, okay, you have just really to prove that the drug is inside. On the other hand, the pharmacologist, why so stupid question? Because we have an effect that is caused because of the presence of the drug within the CNS. Okay, thank you for your attention.
Thanks, Professor Fresta, for your interesting presentation. Any other question?
First of all, your answer. The answer. Or the question.
No answer, just a question. And you're using an epilepsy model. In these models, often the blood-brain barrier is altered.
Sorry?
I say you are using an epilepsy model.
Yes. Actually, yes. That means I use this model, this epilepsy model, just to prove the passage.
Yes, but aren't you enhancing passage because you're using an epilepsy model where we know that we get alteration of the blood-brain barrier?
Okay. The epilepsy model, in this case, is a well-known. Tacrine and the treatment with lithium. And tacrine is the model that is normally used just to study epilepsy, and so just to study drugs, in pharmacology, just to study drugs that act as an anti-epileptic drug. This is, the starting point. This model is so well characterized, just in terms of onset, just in terms of the effect, and so just in this case, delivering the tacrine, this is one of the components that is necessary to scattering all the physiological event. That means the seizures of the electroencephaloccorticographic event. In this case, if we have a carrier, or in any case a strategy that can overcome the blood-brain barrier, or can favor the passage through the blood-brain barrier, we can measure this difference. And so we can measure how suitable is the carrier in this case. And so, I don't know if I was clear enough, but actually we are not studying epilepsy as well. We are, let me say, in this case, we are taking just the model and using this model just to evaluate the passage.
Any other?
I don't know. Okay.
Yes. No, please.
But when you perform your test, permeability test, your rats have developed seizure or not? You are working with rats with seizure, or they are not suitable for seizure. Otherwise, what the colleague said...
just a genetic pathology or something like that?
No, the model. You start your permeability study after that the animal develops seizure? This is the question.
No, just before.
Before?
Just the recording 1 hour before, just the starting, the administration. We administer tacrine, and we continue 2 hours later, just the registration.
Okay.
That means that when I start the registration of the electroencephaloccorticographic registration, I have no administration. Just, let me say, time 0. We have no administration. We wait 1 hour. Afterwards, we start the treatment with free tacrine or tacrine-loaded nanoparticles, cyclodextrin, niosomes, liposomes, I forgot something, would like just to mention, SLN, and so on. The presence of, this conjugation, lithium treatment and tacrine, is the reason that elicit just the seizures. And so we start the measuring. just the presence of scissors, but after, of course, the administration of tacrine, we are able just to recognize the presence of scissors. If I have no administration, I have no scissors.
I see.
Also, sorry, if I would like just to go on. Also concerning the morphological point of view, if I have no administration of tacrine, not only no scissors, but also no damage. Lithium as well, the treatment of lithium alone, cause absolutely no morphological change, no damage, no scissors.
Any other question?
Maybe you can also puntualize on other limits that can have this model compared with the other that are well known?
Actually, I just told you I'm not a pharmacologist. And so, I mean, let me say, concerning other model, and so I turn just the question to the group of Mariangela, I mean, it's the best way. Just concerning, let me the anti-nociceptive model. In this case, you have an answer, yes or not. You have an anti-nociceptive effect or not. In this case, I mean, the measuring of the effect is much more objective because we have really, in case of behavioral, let me say, assay. In this case, you have classical observation by an external to independent observer that judge just the effect. But we have also the possibility to have a morphological advantage in terms of assay. In this case, of course, you can measure the area that was damaged really in an objective way. You can measure, you can trace the area. You can also carry out some immunohistochemical analysis to evaluate the real damage that is caused in each cells. Just concerning the electrocorticographic part, in this case you can study, I just show you the onset of the effect. That means if I have, because in this, what I would like just to stress is the fact that tacrine as well, if I administer tacrine, I have an effect. Tacrine as well as a free drug have an effect. This is the point. In other model, we have, let me say, a peptide that have no effect if I administer the drug. And so what I'm able to see, okay, I have an effect, but it's not so easy to measure, let me say, the rate. In this case, if I have tacrine, the administration of tacrine, in this case, I am able just to measure the effect, the onset. And so any difference in that can be measured. And is a quite sharp measurement of this. That means that I can also measure the kinetic of the process.
Yes. Maybe the only concern, but you are not a pharmacologist, so maybe this is not a real concern, is that, for example, lithium, I know that lithium is, for people that work in neurology, is toxic.
Yeah.
So maybe that there is not a change in morphology, but in functionality. I don't know what kind of functionality can be lost.
Okay. I would like just to answer you, of course. Okay, treatment with lithium chloride. Okay, the level of lithium that is needed just for this experimental model is not so high. But in any case, don't think about the concentration. After 24 hours, we start just the treatment. That means that we have not a huge time just to have, let me say, a chronic effect. Of course, just to be honest, if I don't know, if we have really an acute effect of lithium, I don't know if anybody just sitting or in this room can answer this point, but let me say, the amount is small, what I can assure you, And also, we have just one administration. We have not various chronic administration of lithium just to have this effect, because we want the lithium just within a CNS. Afterwards, we administer tacrine. I mean, these two components make this kind of damage, this kind of alteration of the electrocorticographic pathway.
Okay, is a question?
Massimo. The net result of this interesting model is the onset of the activity. You have 10 minutes for nanoparticles, 22 minutes for tacrine. And of course, in these 10 minutes, the drug tacrine has been released by nanoparticles inside the brain. Otherwise, you have no effect. In your forecast, with your big experience in this area, do you think that this 10 minutes different could be enough for other carrier system, or there is the risk of a confusion or overlapping of the results with liposomes or the micelles and so on?
Okay, this is a really nice question.
Maybe yes, because 10 minutes is the double, but
yeah.
Do you think that the release of tacrine from the system is so
okay and
so important or not?
Let me say, depends on the drug. Depends on the drug carrier in this case. That's for sure. Just thinking on cyclodextrin, let me say, if we can imagine a cyclodextrin, just to image, and a cyclodextrin that complex tacrine. In this case, when cyclodextrin trespass the blood-brain barrier, in this case, we have no presence of tacrine. That means, in this case is the chemical part, fortunately. In this case, the equilibrium is formed really quickly. It's a question of seconds in this case. Of course, you have also the diffusion, and so the gradient that is formed just in this case. But, the presence of tacrine in this case is absolutely immediate. Yeah, tacrine hydrochloride. Just to imagine. It's not a concrete example. Of course, depends on the carrier. In principle, what is really, let me say, nice, under my point of view, the possibility just to have this kind of discrimination. I can measure exactly, because I am able just to recover and to record the electroencephalographic pathway really time by time, because I have an electrode that measuring all time long.
This case is very net, but for example, tacrine, it's possible to use tacrine as a free base, as a lipophilic, because if you want to study SLN or micelles,
in principle, I can answer yes. In this case, because is really we focus just on the possibility of using this model just to study the passage through the blood-brain barrier, and in principle, yes. Of course, why we use tacrine hydrochloride? And we are back just to the pharmacological point of view, because I need just to administer as a free drug, as a solution, and we need a solution as a free base. Of course, we have the problem that the administration, the IV administration, I don't know the solubility of the free base, but in principle, okay, yes, it could be.
With the lipid-based carriers, it could be a problem to encapsulate. If you want to taste SLN or micelles.
In this case, in fact, I just at the first slide, I focused just on hydrophilic drug. The problem that 90-80% of hydrophilic drug are not suitable just for, and so pharmaceutical companies are really disappointed on that. Are not useful just for the clinical management of pathology at the level of the CNS.
Any other question? Yes.
Just a quick one. With your system, you propose to use this model to evaluate different delivery systems and eventually to show which one is working well or better. How confident are that once you prove your system, your delivery system with tacrine, when you change the drug that has to be delivered with another drug, with a peptide, with a monoclonal antibody, with a gene? Is it working the same way, or the delivery system can be linked to the drug that has to be delivered? So this is the limitation I see in your model personally.
Actually, this model, and of course I'm proposing, is based on the study of the carrier. Of course, if we change a drug, of course, everything is changed. That means in terms of encapsulation, that means in terms of release, that means in terms of everything. But just looking at the possibility to have a strategy, a delivery strategy, and just to study the delivery strategy, because a lot, it is normal. If you change a component, we can change. We know as a chemistry that if we change a little small component, sometimes happens that change absolutely everything in your systems. But on the other way, we have the possibility to have active targeting. Think about the active targeting. In case of active targeting, the first answer that you have just to answer is your strategy. Let me say, the case of the presentation that was carried out just before my presentation. And so the glucose derivatization just to be inserted in an iosome systems. At the very beginning of my research, as it was well puntualized, my question that I would like just to answer, this strategy is a nice strategy or not? In this case, the model is really nice. Of course, just thinking the therapeutic point of view, of course, the real model is just let me say, the question that I put everybody just sitting in this room. Of course, if I would like just to study an ischemic event, of course, I have just to prove the ischemic event and the efficacy in terms of therapeutic effect.
Any other question? Thanks, Professor Fresta, again, and the section is closed. Sorry. Sorry.
Listen, if I have understood correctly, the model works since in 20 minutes, Tacrin explains its effect within the liquor, okay? And you can say that nanoparticles are passing through the blood-brain barriers because the effect of nanoparticles is within 10 minutes, okay?
Yeah.
But if another drug delivery system needs more than 10 minutes to cross the blood-brain barriers, for instance, 1 hour, 2 hours, the model does still it work?
Yeah. Okay, just work on this hypothesis. Of course, I mean, we have just to carry out experiments. This is a preliminary communication, of course. But think about this hypothesis. If we have a carrier, and if this carrier is able just to pass the blood-brain barrier after 3 hours, let me say, what do you expect? I expect that just at the very beginning, if the carrier works well, if the carrier is not able to leak the drug that is inside, that I have no effect. I record no effect at the very beginning of the experiment. I will be able to see an effect after 3 hours. I have absolutely no limitation, let me say in this case, no limitation in recording just the electroencephalographic pathway. I have, in principle, no limit. Up to 24 hours, the pharmacologists that I work with, are able just to carry out this kind of recording. And so I'll be able just to discriminate the effect. And so, this is, under my point of view, of course, it's not a definitive, let me say, answer. But at this moment, under my point of view, this is an advantage because I'll be able, in principle, just to discriminate the effect.
Okay.
Any other question? Sorry. Thanks, Professor Fresta.